Hello everybody to our seminar here at the University of Leipzig in the Institute of Animal Hygiene and Veterinary Public Health. We have with us Navdeep Sidhu. He is an Indian physician scientist who is currently living in Germany. He studied human medicine at Charles University, Czech Republic, and received a doctorate degree from the University of Goettingen, Germany, in the field of X-ray crystallography. He worked as a junior physician in internal medicine and paediatrics, and he was involved in the public health response to COVID-19 pandemic in Leipzig, particularly in care of cases and cases and isolation and quarantine, especially at home. It's very important to say that all the information here, which Dr. Sidhu will tell us, it's his personal opinion, has nothing to do with the health authority in Leipzig. So, Dr. Sidhu, the mic. Okay, now you can go ahead, please.
Okay. First of all, thank you, Professor Abdul Wahid, for your kind invitation and introduction. And thank you, everybody, for joining in today. The title of the seminar today is Care in Crisis, Home Follow-up of Cases and Contacts in the COVID-19 Pandemic. Imagine you already know that there's an outbreak of a novel infectious disease somewhere in the world. You are in a neighboring country, you are being vigilant, you learn of somebody showing similar symptoms or signs in your country. So what you can do is you test the person, and on confirmation, you place them under isolation for the duration over which they are infectious, which you probably already know from previous literature results. So this would be your case. This is the patient, and you can find out who the patient was in significant contact with over the time period when they were infectious, and these would be the contacts. You place the contacts under quarantine for the duration of time over which the disease should manifest itself if they really were infected. If you can do this well and fast enough, faster than the virus spreads itself, you can break the chain of transmission. The outbreak stops there. This is what the WHO recommended that countries do, to test, trace, and isolate. Now, if you were falling behind, you could introduce some graded measures, starting preferably with relatively light social distancing measures, for instance, and see if you can make it work then. The advantages that lie in this response model are that you don't overburden your healthcare system. You can focus on home follow-up of cases and contacts. If the cases have symptoms which worsen, you can provide help early. If contacts develop symptoms, you can test them early. If you find new cases among contacts, you repeat the above procedure for each new case, that of identifying contacts and so on. So it is very simple and straightforward, and many countries could implement this suggestion from the WHO very well, including including countries in the global south, which are relatively poor. And yet many countries, including otherwise relatively rich countries in the global north, failed to implement this simple system. What countries did it well? Well, Hong Kong did it pretty well. It is close to Wuhan, China, where the COVID-19 outbreak started. Hong Kong has a population of about 7.5 million. And yet, in the first wave of COVID-19, it reported only 4 deaths until roughly the beginning of May. Other countries in Asia that were able to launch well-organized pandemic responses on this model included many in Asia, including China, South Korea, Singapore, and Taiwan. For examples in other parts of the world, for instance, Germany in Europe did very well too. In Africa, Sierra Leone reacted fast and efficiently with rational measures as early as February 2020. New Zealand eliminated COVID-19 by May 2020. In Veneto, Italy, home-based care, sufficient testing, and early diagnosis were associated with 4 times lower mortality rate than that in Lombardy, also in Italy. Now, what if, so it really worked in many cases for many countries. Yeah. Now, what if you can't do contact tracing fast enough? One might ask. Well, then, as a first step, you can try to improve yourself. You don't have to give up. So you can train contact tracers. In the Ebola outbreak in Sierra Leone, for instance, former patients were trained to do this. In the campaign to eradicate smallpox in India, some of the best proxy contact tracers were school children. They often walked to schools from neighboring villages daily and knew all about who was sick in what village and when. These were examples of the power of community-based participation, which was also crucial in advances in healthcare in the fight against HIV/AIDS. Also, for instance, in Balochistan, smallpox was eradicated mainly through a contact tracing effort. Afghanistan had highly efficient contact tracing teams. They eradicated smallpox earlier than neighboring Pakistan and India. What's more, even after having done so, Afghanistan did not close its border with Pakistan to seasonal migrants who migrated yearly as they had always done, sometimes including the sick. So the Afghanistan health authorities just patiently continued doing their work as if they were dealing with their own population, essentially doing part of Pakistan's healthcare work for them. So talk of migrant friendliness. A poor country with high illiteracy rates was displaying a highly educated, civilized response and winning the fight against a deadly pandemic, smallpox at that time. Now, in talking about such community responses, Kickbush and colleagues wrote in the British Medical Journal, quote, African countries with recent experience of Ebola will probably better understand the value of community involvement than the global North. Learning from others and from Asia and Africa is becoming essential, unquote. In the COVID crisis, COVID-19 crisis, many countries, however, failed to do this well, as I said. But what's sad is that they also threw up their hands. Instead of trying to do it better, they just stopped doing contact tracing, it seemed, for quite a while at times. One of the most fitting comments to the problem that I know of was penned by Sarah Dalglish of Johns Hopkins School of Public Health. Writing in the medical journal Lancet in April, she said the US and UK had shown, quote, among the world's worst responses to the pandemic, unquote. And not only that, she wrote how the US, by not easing sanctions against Iran, Venezuela, and Cuba, had made it difficult for those countries to launch an effective pandemic response. The US would later try to undermine the World Health Organization right in the middle of the pandemic. And the WHO was the organization that played a crucial role in the eradication of smallpox and in organizing the fight against Ebola in Africa, among numerous other services for decades. Dalglish reminded us that despite early and appropriate public health responses in many African countries, quote, relatively little has been heard on the global stage about these efforts or from African veterans of the Ebola epidemics in West Africa and Central Africa, even though COVID-19 appears to spread in similar ways through family clusters, unquote. And despite the illegal sanctions against it, Cuba was helping other countries respond to the pandemic by sending physicians to those countries. The sanctions against Iran, by the way, were making it much easier for COVID-19 to spread across borders to neighboring Afghanistan and Pakistan, also countries of global South. So how did we get here? And what were the reasons for this massive failure in pandemic response? The connection between human and veterinary medicine is an intimate one. One way to see this connection is if we consider the following. According to one classification scheme, there are some 1,400 species of infectious agents that can cause disease in humans. Out of these, the majority, about 60%, can shuttle between humans and animals. They are zoonotic. Coronaviruses are an example. Also, many human infectious diseases are thought to be of animal origin. These include those from domestic animals, for example, diphtheria, influenza A, measles, mumps, pertussis, rotavirus, smallpox, and tuberculosis. And from apes, for example, hepatitis B, from rodents, for example, plague and typhus. Those having wild, non-human primate origins include AIDS, dengue fever, vivax malaria, and yellow fever. The first ever coronavirus-caused illness is believed to be one reported in a cat by German veterinarians just over a century ago in 1912. Dog coronaviruses can sometimes cause disease in cats. Cat viruses can do the same in pigs. So in humans, 4 known disease-causing coronaviruses were known until 2002. They typically caused mild illness of the common cold variety in healthy adults. But then in 2002-2003, there was a deadly outbreak of severe acute respiratory syndrome, SARS. A coronavirus was identified as the causative agent. The virus had originated in bats, but infected humans apparently through civet cats as intermediary hosts. How did this happen? Well, there's a global demand for wildlife trade, and it is not limited to China, as some politicians and media stories seem to suggest. In these wildlife markets, diverse animal species are artificially brought together and often kept together in overcrowded, unhygienic, and stressful conditions, even for the animals. This facilitates both disease eruption in the animals and pathogen transfer across species, including ultimately to humans. And this seems to have been what happened in the SARS case. Indeed, a recent editorial in Nature, Ecology, and Evolution recommends that wildlife trade be permanently banned for this reason. But it also correctly suggests that such measures should involve community inclusion in decision making, finding sustainable alternative incentives for suppliers, and so on. The problem lies not with the wildlife itself, it suggests, but with the human destruction of their environment through climate change and otherwise, and with human exploitation of wildlife. A decade after the SARS outbreak, in 2012, there was another new disease outbreak, this time of Middle East Respiratory Syndrome, MERS. The Egyptian virologist A.M. Zaki did some excellent scientific detective work there with this disease, under difficult circumstances, and showed that a novel coronavirus was responsible for this disease. This coronavirus had originated in bats and infected humans via dromedary, that's one-hump camels. Now, the close connection between animal and human health means we need to invest more into research and monitoring, not only of human, but also of veterinary diseases. Ironically, though, at the end of 2019, just as COVID-19 was to rise, the United States Agency for International Development, USAID, stopped funding one such major worldwide veterinary pathogen monitoring program called PREDICT. The program had also provided scientific training to thousands of people in Asia and Africa. So even if we limit ourselves to coronaviruses, we had been given plenty of warnings over the last 2 decades, if not longer. And yet, when COVID-19 hit us at the end of 2019, we had not developed any vaccination or drug against any of these viruses. Another factor that caused our bad response to the pandemic was our bad response to the 2008 financial crisis. This was caused by willful downplaying of systemic risk by investment banks. However, rather than us letting them pay the costs of their risks, we gave them insurance ex post facto from the public chest. As the Nobel Prize winning economist Joseph Stiglitz explains in his book, The Price of Inequality, the investment bankers laughed all the way to their banks. Since we had taken over their costs, ideologues claimed that we should now cut services for the public because there wasn't enough money. Of course, we had taken on their debt of the investment bankers. This is when the financial crisis was needlessly converted into an economic crisis. These austerity-driven cut-downs in essential services, research funding, and government labs and regulation, health infrastructure would leave many countries badly prepared for the pandemic. Now, similar neoliberal policies have been doing damage to the infrastructure in that manner since the 1970s. Quarantine of cases and contacts has been used in human history at least since the 14th century in Europe. And yet, many countries failed at that in the 21st century. Even personal protective equipment was lacking for healthcare workers. As the medical anthropologist Susan Erickson pointed out in the journal Nature Human Behavior, too much was left to the market. In her words, quote, just-in-time supply systems in which companies deliberately avoid stockpiling and order inventory on an as-needed basis were imposed on societal sectors, including health, unquote. She mentions how the government of Sierra Leone was, quote, forced to embrace macroeconomic austerity plans as a condition for getting cash to build hospitals, roads, and utilities. And that aid for infrastructure was often conditional on spending 40 to 70% on private sector business from the donor country. Depriving aspiring, newly independent post-colonial young economies of new business development and sovereignty, unquote. Although Sierra Leone and other African countries reacted early and well to the crisis, options available in general to countries in the global south would get increasingly limited. In May 2020, for instance, Kavanagh and colleagues pointed out in The Lancet that many African countries could not get hold of needed supplies because, quote, geopolitically powerful countries were mobilizing economic, political, and strategic power to procure stocks, unquote, at the expense of countries in the global south, of course. Meantime, countries like Malawi only had 25 critical care beds for a population of 19 million. The establishment of the Africa CDC in 2017, Centers for Disease Control, has helped Africa to begin to address some of the problems in an efficient manner. For example, by pooling demand, in which manner they acquired 100,000 tests from Germany, for instance, in April 2020. But much more would be needed. According to them, according to Kavanagh and colleagues, health needs to be considered a, quote, global public good, unquote. Thus, Lancet Global Health editorial appealed correctly against, quote, asymmetrical power structures and the largely high-income country concept of global health and development, unquote. Similarly, Orcutt and colleagues writing in Lancet called for, quote, inclusion of migrants and refugees in the COVID-19 response, unquote. And the plight of migrants and refugees has been increasingly ignored during the pandemic and made even worse, for example, at the US border with Mexico. Voices can have an effect. The UK initially went for the so-called herd immunity idea. A British medical journal editorial by Kickbush and colleagues would describe UK and US as, quote, countries that were initially willing to allow some older people to die, unquote. It's only later that they began changing policy. Now, even after the quote herd immunity policy had been discredited in the UK on June 2020, the medical journal Lancet devoted an entire full-page editorial comment to serious consideration of a quote novel solution unquote to overcome the COVID-19 outbreak in the UK, proposed by an unnamed professor of medicine and epidemiology in England who was close to the government. And this idea was for the government to, quote, encourage everyone under 40 years to go out, get back to work, and if at all possible, do all they could to become infected, unquote. And their hopefully acquired immunity would then, quote, protect the entire population, unquote, and ease pressure on test, trace, and isolate, they said, also a quote there. The Lancet did not quite advocate the proposal yet because of practical considerations, they said. But my point is that the fact that such a scheme could be seriously considered speaks volumes about the failure in fighting the pandemic at home in the UK. However, a response has also got to be balanced. Yeah, a severe lockdown put in place at a moment's notice without sufficient preparation brings about with its own death toll, virus or no virus. The planet has a workforce of about 3.3 billion people. Most of them, 2 billion, actually work in the informal economy. And these people are highly vulnerable and often have little savings. On April 7, 2020, therefore, the International Labour Organization, which explains these things, announced that, quote, as a result of the economic crisis created by the pandemic, almost 1.6 billion informal economy workers have suffered massive damage to their capacity to earn a living, unquote. The drop was especially severe in Africa and Europe. The ILO noted that if left with no alternatives, quote, these workers and their families will have no means to survive, end quote. In other words, given the economic crisis, we needed to provide a safety net to over 1 billion people to merely survive. Understandably, many of them were more afraid of hunger than of COVID-19. And who can blame them? Similarly, in a harsh lockdown, maternal care and many other health services suffer, as was also found out in Africa during the Ebola crisis. So all this has its own death toll, and we need to also try to avoid that. To end, I would give an example from India, which instituted a particularly hard lockdown with 4 hours notice at 8 p.m. local time on March 24, 2020. Critics called this too much, too late, quote, too much, too late. In a country in which food relief is mainly based on ration cards, at least millions, if not more, of people lacking ration cards were initially left to their own devices in the government's relief package, according to the Indian economist John Drays. Now, what's left for us to do as we go forward in the pandemic is to try to create equitable solutions also in the vaccination program, and also to do a lot more research so we can try to better understand how exactly did we fail worldwide, and so that we can learn some painful lessons for the next pandemic, not only for the next pandemic, but also for this one, so we can better cope with it. Thank you very much. Just a second. I think I've lost the voice there.
Wonderful presentation.
Yeah, thank you.
And an overview you have given us about the coronavirus in general, and specifically for what we can do in order to improve our response to this outbreak. It's really impressed. What I would like to ask you, you have mentioned Sierra Leone a lot and Africa, and I think with Sierra Leone, we know that the Ebola outbreak hit this country very strong. in 2014, 2015. I think they have learned a lot from this outbreak. I think Africa, as a general, they have collected a lot of experiences during the last few years about outbreak control. I think their response it is really better than the response in the Western country. Let's say it like
That's right.
this. And can you comment more on that, please?
Yeah, it's quite amazing, actually. If you look at, I was just today looking at the curve that New York Times has for Sierra Leone. It's basically a flat curve throughout. Yeah, so it's quite amazing, and kudos to them. And so I think here in the global North countries, we should be asking ourselves. Of course, one can argue that part of that could be, due to testing deficiency or something of that sort, which could be part of the reason. But I think even if you look at the initial phase when actually Sierra Leone was testing enough also on airports and placing people under quarantine when they came in at airports, you could see that they were actually doing really well and managing the pandemic well. They had placed, sanitation areas in cities and so on. So I think there's something for us to learn there from African countries, as was one of the comments there from people writing in the medical journal there. Yeah, so very impressive, and something we should probably be going to Africa more to be able to learn how to do things better here in Europe.
Especially also, you're speaking morely in more about East or West Africa or Sub-Saharan Africa, not about North Africa, because I think the number of cases in North Africa is more, very north and very south. In Africa, you see more cases than in the area of East, West, and Central Africa, and I think also maybe the reason is that the more north and more south, they have little outbreaks, but the outbreaks more focused to the center, east, and west. And for that, maybe these countries, not Africa as a whole, but we need to look to the countries which is really lie in the middle of the African map, where they have many outbreaks like arboviruses, hemorrhagic fever viruses, where they learn a lot from these outbreaks and how they control it. So, but you are right. This is a very important point to mention.
Actually, I was hoping that I could also ask a question. I could put a question to you, because this is something that you could address better than me. And that is, I left this question unanswered here. What do you think is the reason for there being so much of testing capacity deficiency in so many parts of the world? What are the reasons for it? How can we better that? You are very closely involved, I know, with testing in Africa and other places. So that's, I think.
I thought that I'm the moderator of it, but anyhow, I think I tell you the problem. The problem that the big problem nowadays, and this outbreak has teach us, is that if you don't have a local production, you lost. This is a big issue nowadays. So India, China, European country, USA has a very good local production of diagnostic tests. And for that, they are very fast for distributing and covering the diagnostics for many areas in a very short time. The problem in Africa, we lack a well-structured local production of diagnostic tests. And if you don't have this, you will have a big problem. So this is, you need to always see which country has a local factory to produce diagnostic kits and which not. And I'm sure the country which do not have a local production, they don't have a very good testing, and they are waiting to receive kits from other country. And of course, each country, make their own country as number one, and then the rest they can take care later. The big problem we are facing, and this we must keep in mind, is that if a country nowadays work alone and establish their own rules, this will affect the whole world. We are not living anymore in a small island. We are living in a world. Everybody doing anything in any place in the world will affect the whole world. For that, if the USA don't make a really shutdown, and or not a 100% shutdown, but a really kind of taking care of what they are their shutdown, how they can take with the people, how to isolate people. If they don't take care of this, there will be a big problem everywhere. For that, we need to have a universal action. We need to just forget our background, forget our religious background, forget our traditional background, and come up with one plan. And if the people does not realize that, we will have COVID-19 for longer time staying with us, and we will have this big problem coming over and over again.
And also maybe a new epidemic or pandemic erupting, God knows when.
Yeah, of course.
Yeah, especially with the destruction of the environment, we're in the middle of a major extinction being caused by humans on the planet. So, you get more of a possibility of more pandemics erupting in the future.
And actually, what's also very important for your presentation, that tracing and home isolation, it's one of the most successful strategies to stop this outbreak of expanding. We have also our experience with asymptomatic patients. What do you think about? Because usually, and you would say, okay, if you come from travel or you contact people, isolate yourself for 2 weeks. Some people said after 2 weeks you can go, you are free to go, but some said no, you are free to go only after testing. And we have discovered that there are many people which we said, okay, please isolate yourself. They are positive, but asymptomatic. And I think not every institute or every authority has the luxury to test everybody in the isolation. What do you think about that?
Well, yeah, that's another aspect. And the problem, for instance, was also in terms of, I think we need more testing capacity, that's for sure. And then another problem is that even if they are positive, are they really infectious? Or is that just, because we are testing for mRNA and not for the infectious virus particles? So that's another open question. And then, the same problem also. So yeah, it's an open question, and we need to properly address it. Sure. Yeah.
Well, it's a part of life to have your kids around you, know.
Thankfully.
Yeah. So that's mean asymptomatic patient. It's become a very big black hole in this outbreak.
Yeah, sure.
And it will continue like this, I think, unless we have a luxury spending into testing many people to get the asymptomatic. And as you said, it's not everybody, even with the symptomatic is positive, can transmit the infection. Yeah. Sure. But we need to know if with coming of these new strains, this will change. Because the new strains, we know that the vaccine can still work against this strain, but at the same time, we know that these can be highly transmissible. So that means it might be that our knowledge of not every PCR positive will be also transmissible, can transmit the infection to other. One very important really point you have mentioned in your presentation is migrant, and how this is the lost community in this control programs or the contain of this outbreak. Can you comment on that?
So I think migrants and refugees in general have been really ill-treated, and also their rights have for years have been ignored. For instance, also their right to apply for asylum, and the reason that we have these overfilled refugee camps is because we have really chronically ignored their rights. So according to the the refugee convention, they should be able to apply for asylum and to any country. They don't need to be. We don't have to create a fortress Europe and just overburden countries at this or that end, and because that's actually against the law. And also it's also part of the law. It's actually since at least a century and going back even further, that you have to provide in the Mediterranean Sea, safe passage, or you have to pick up people who are in trouble. This is also part of the law, and pretty much all European countries are ignoring these, really long-term laws, which are creating a huge loss of life itself. So really, it's a very sad story, and I think we need to, get together and organize in an organized fashion to better the respecting the rights of migrants and refugees. It's a huge, very sad.
Yeah, and this has come also because some people do not have the luxury to isolate the infected person in a separate place with separate toilet or separate facility. So what's your comment on that? How we can really isolate ourselves if, for example, my daughter is ill, confirmed COVID case, I cannot tell her can stay in another home because I don't have another home.
That's right.
What we can do in such cases?
Yeah. So I can give you a hypothetical scenario. So also after moms deliver babies, they need to, for instance, in the hospital, and then they need to go home, where they might have a contact person. They might not be able to isolate themselves from the father, let's say, who might have, and we've had cases like that. So you have to give the physicians or healthcare workers some money, so that they can allocate money and take care of these people's needs under times like that. For instance, so I think we need to drop this whole austerity baggage. This has been totally disproved as viable. Its viability has been disproved, and we need to drop it and really put more money up front to be able to help people. And we just need to, better the living conditions of a lot of these migrants and refugees in the refugee camps, resettle them. I mean, that's when Russia occupied Hungary. There were thousands of people who left Hungary at that point, and they were resettled in no time. Many countries actually took these refugees over, and they were considered prima facie refugees. Yeah, so they didn't have to go through all this sort of lengthy processes that we are demanding now of people when they're coming from other continents. Why? If we could do that for Hungarians, why can't we do that for people from Iraq, from Syria, from Afghanistan, Pakistan? Where have you? I mean, almost every country has political violence problems, and everybody has a right to be heard, regardless of what country they come from. So this whole thing about there being safe countries and so on, that's really also in itself a sad thing, because we're basically telling these people that no, we won't even hear your stories. Yeah, so very, very, very sad.
Yeah, and this is bringing news, for example, that when this is always happening a lot in Germany, that we deal a lot with the people coming from outside Europe, during this crisis as highly infectious, while we are dealing with within Europe travel as secure. And I think this is bring us to a big problem in Europe, that in Europe everybody said, if you come from UK, Netherlands to Germany, you are very clean, but if you come now from X country outside the European country, you are not clean. And you deal with them as highly infectious, while your own European is not. And we now learn for sure that the second this wave, what we started is does not start in China. It starts within Europe.
Sure.
Yeah.
I think part of the problem and part of the we should be wondering why when we could take care of the first wave pretty well, how come that we have this whole dimension change of a problem in the second wave, when we should have actually not only learned lessons from the first wave, but also in the meantime, when we had flattened the curve in many countries in Europe, including Germany, for instance, what could we have done to help other countries deal with the pandemic in the meantime, so that we, when we send our tourists there, for instance, they don't bring those the same virus back to us. So I think if we had probably helped other countries more, we would have also been better off during the second wave. So this whole solidarity that has been missing has been a huge problem. And I think one of the big problems actually has been our subsidizing tourism, while at the same time ignoring the plight of refugees who were actually had no significant outbreaks in the refugee camps at that time. And so we have just let those refugees fester under those conditions until it was clear that at some point it will become inevitable that they will catch infection, and then under these overcrowded conditions, it will spread like fire, the pandemic there. And I was watching the other day a BBC story from a London hospital where the doctor was saying that people in their 30s and their 20s are dying of COVID. So we should be wondering, well, what's going wrong there, but also what's going wrong with our totally different standards that we're using for a whole huge subset of people, about 70 million people out there who are violently displaced and need help. That's roughly the number of people who were killed in the Second World War. We couldn't save people there. Well, we can save people here. So maybe that's another reason that we should be actually opening our arms and trying to help these needy people. They're not leaving their homes just for nothing. Nobody puts their whole children and their lives at risk trying to cross the Mediterranean unless they really think that they have very few options back at home.
So many thanks, Dr. Navdeep, for this overview about coronavirus and how to take care of infected cases or self-isolation, an overview about the outbreak in general, how Africa dealt with the outbreak so far better than other countries, how we need to take care of patient or people need more care from us as other persons, and how we can collaborate globally in order to control this outbreak, not having individual reaction from individual countries. Many thanks for being with us. It was an honor having you, and until next time.
The honor is all mine. Thank you very much for having me.
Many thanks. Okay, bye-bye.
Bye-bye.